Good morning, everyone. My name is Janka Kovács, and my research topic is life-changing treatments in central nervous system diseases, ventriculoperitoneal shunt, and targeted therapies. I work as a resident doctor in the second Department of Pediatrics. My supervisor is Miklós Garami, and my scientific methodology supervisor is Vanda Máté. My vision is to improve the quality of life and extend the life expectancy of children treated with brain cancer. And my mission is to achieve my vision, to provide guidelines for the treatment of diseases involving the central nervous system, like malignancies and hydrocephalus. These are my two ongoing projects. On my first project, I focus on ventriculoperitoneal shunt infections, and my second project is about targeted therapies. My first project is investigating the efficacy of antibiotic prophylaxis in preventing bacterial ventriculoperitoneal shunt infections. A little bit about the background. So 1 in 500 to 1 in 1,000 babies are born with hydrocephalus, but there are also various other causes that can cause a secondary hydrocephalus. For example, intracranial hemorrhage, malignancies, trauma. The most common treatment for hydrocephalus is a ventriculoperitoneal shunt, and an estimated 30,000 ventriculoperitoneal shunt procedures are performed yearly in the United States. The problem is that the incidence of infection is still unacceptably high. It's between 3 and 20%, and it can cause devastating consequences. For example, the mortality is 2 times higher, and that could cause a cognitive impairment. And it goes also with a lot of expensive and invasive procedures. That's why our aim is to compare the rate of bacterial ventriculoperitoneal shunt infection with and without antibiotic prophylaxis. We would like to conduct this meta-analysis in all patients with ventriculoperitoneal shunt, so also adults and children. The antibiotic prophylaxis will be an antibiotic impregnated shunt, which is impregnated with rifampicin and clindamycin, and the outcome will be the incidence of bacterial infection. Our clinical question is, does antibiotic prophylaxis change the incidence of VP shunt-related bacterial infections? And we hypothesize that it does. The rate of bacterial infections decrease with antibiotic prophylaxis. The clinical implication is to provide an evidence-based guideline to decrease the mortality by decreasing the bacterial ventriculoperitoneal shunt-related infections. I conducted my systematic search at the end of November, and I had more than 10,000 hits. I had 3 domains. The first domain was ventriculoperitoneal shunt domain. The second was infection domain, and prophylaxis and treatment domain. After the duplicate removal, I had more than 6,000 articles. Based on the title and abstract selection, I had 55 articles, and on the full text selection, finally, I have 34 eligible articles. This is my second ongoing project, which is precision therapy with the oral anti-cancer drug dabrafenib in pediatric brain malignancies. About 30% of childhood malignancies are different types of brain cancer, and the 5-year survival rate is in children younger than 15 years old is about 75% with the conventional therapy. The conventional therapy means surgery, chemotherapy, and radiotherapy. But based on the next generation sequencing, we can also use targeted therapies. For example, in case of BRAF mutation, dabrafenib showed meaningful clinical activity, and tolerability was acceptable also in children. In the second Department of Pediatrics, we use this BRAF inhibitor for different types of central nervous system malignancies, for example, like pilocytic astrocytoma. The oral dose is between 3 and 5.21 milligram per kilogram daily, and dabrafenib highly bound to plasma proteins. Based on the preclinical mice models, it can also penetrate the intact blood-brain barrier, but we only have non-human primate models about the cerebrospinal fluid pharmacokinetics of these BRAF inhibitors. That's why we would like to define the optimal dose of dabrafenib in children treated with brain cancer, which can also reach an adequate cerebrospinal fluid concentration. We will conduct this observational study in the second Department of Pediatrics. The population will be all children treated with brain cancer. The exposure will be oral dabrafenib therapy based on the next generation sequencing result. And the outcome will be the exposure and the pharmacokinetic characteristics of dabrafenib in the blood and also in the cerebrospinal fluid. Our clinical question is that how can dabrafenib doses be optimized individually by monitoring drug levels in blood and also in the cerebrospinal fluid. Our hypothesis is that oral dabrafenib therapy cannot reach the therapeutic level given in the usual dose. The clinical implication is to provide recommendations for optimal dabrafenib dose. To summarize, I'm going to finish my 2 projects at the end of summer 2023. And my favorite quote is from Kurt Vonnegut, who was an American writer, "Science is magic that works." And thank you for your attention.
Thank you, Janka, for your excellent presentation. I would like to know what is the definition of the shunt infection and what kind of symptom cause this kind of infection? So.
Thank you for your question. So in the most articles, the definition was also a positive cerebrospinal fluid culture and elevated laboratory levels like white blood cell count, CRP, and also clinical symptoms like meningism, headache, fever, cognitive delayment, for example.
So congratulations on your presentation. And my question would be that what antibiotic is used mostly perioperatively?
Thank you for your question. So this is to my first project. Okay. Before the ventriculoperitoneal shunt procedures, like 15 years earlier, they only gave 1 dose cephalosporin, but right now they gave 1 dose vancomycin and 1 dose cephalosporin 30 minutes before the surgery, and it depends on the hospital whether they continue it for 1 day or for 72 hours.
I'm Miklós Szabó from the Division of Neonatology, and congratulations for this nice work. I have a question to the first project. So in preterm infants in post-hemorrhagic hydrocephalus is increasingly popular to use subgaleal shunt or ventricular access device, which is like the Portacat. And I just wondered whether did you consider to include these new methods into your survey, and if you consider why you did not use as Sarge keys these ventricular ventricular access device and subgaleal shunt?
Thank you for your question. So, as I mentioned, I have already conducted my systematic search, and I only included those articles which wrote about the original ventriculoperitoneal shunt. So.
Okay. Thank you.
Thank you.
Can I ask one question? Your second project, I mean, I'm very innocent on this field, you see. So there are different types of brain tumors. Are the same dose is the same dose used for all kind of tumors? Because the access to tumors could be quite different actually by a drug. So are there differences on this when you say that they are clinically effective therapeutic level? Is this the same for all tumors, or do you just have to do some kind of differentiation between different kind of tumors?
Thank you for your question. So they use oral dabrafenib in case of BRAF mutation based on the next generation sequencing. We don't really have data about the drug level in the cerebrospinal fluid, so we use this dose, what I wrote on my presentation, and they look for the clinical symptoms for toxicity and if it's effective based on the MRI pictures. So they use the same amount, but maybe we can do subgroups.
Okay, I'm just curious, you see. I mean that you will be the expert on this anyway, but you are already the expert.